we're going to move on to in fact, it leads on from a couple of questions about can pharmacists refer in, the issue around polypharmacy and the harm that comes from it. So I'm going to ask Nigel Beckett, who is a consultant colleague of mine from Guy's and St Thomas's, and a geriatrician, to talk about multi-morbidity models of care that we have in South East London. Over to you, Nigel.
Thank you very much, Dagny. I've held various positions, but I'm now just one of those little jobbing geriatricians who are getting on with things. And what I'm going to try and talk to you a little bit about is a bit of a novel approach. And this is really a very live conversation. And it's about a multi-morbidity model of care project that's ongoing in South East London. And I think I should probably acknowledge that people like Krishna and Robert at a sector level, at the ICB level, are very much driving this. So this is very much about something happening about South East London. And I'm involved really from a Lambeth perspective. And I'm particularly involved because my particular interest is in cardiovascular disease. So next slide. Always nice to start with a quote from someone like Chris Whitty. This is from an editorial from the BMJ from about 5 years ago now. And the concept that we're pretty good at single disease in the NHS, but we're not good when it starts coming to multi-morbidity, when you've got conditions coexisting, either in a horizontal or in a vertical integration process. And this was written with the presidents of the Royal College of Primary Care, surgeons, physicians, and we do really need an intellectual shift in how we adopt our research, our training, something that's particularly I'm passionate about in terms of the generalism rather than the specialism that we get so much of. Next slide. So this is quite recent data. This is from only a couple of years old, and is based from looking at NHS data in just short of 4 million individuals and looking over 308 conditions. And what it tells us is what we sort of already know, that first of all, multi-morbidity is very common. It doesn't matter whether you talk about multi-morbidity as being 2 or more long-term conditions, where we think of it as basic, or more complex when you're thinking about 5 long-term conditions. It is extremely prevalent. It is more prevalent as you get older, and it's going to be very much the future. It's only another 25 years until we're midway through the century, and 84% increase, and about 35 million people in the UK will be considered to be multi-morbid. And the greatest increase will be in the most deprived areas. And in terms of cost, if you compare people who are multi-morbid against people who are not multi-morbid, there's anything from about 1.3 to nearly a 3 times higher cost implication. So the cost burden to the healthcare system, and I include social system in that, is phenomenal. And picking up on the last presentation, 1 in 3 people who turn up to ED have 5 or more long-term health conditions. Now, 10 years ago, it was 1 in 10, and that just gives you a feel for how things have changed. Next slide. So some of the challenges, and we've talked about this. I think first of all, there's the issue is that there aren't going to be clustering of diseases. So my interest is cardiovascular disease, but people who have got CKD, often are diabetic, have heart failure, on top of other aspects as well. But there isn't an overlap of very common problems, such like reduced mobility, chronic pain, isolation, and a real impact on mental health. The problem we have is the system still has a tendency to focus a little bit on individual diseases. We're still too focused on individual diseases when we're talking about some of our training. And I really don't think we have enough generalists in terms of our training. A lot of our drug efficiency are all, again, very much focused on single conditions. And we've touched on this already, that we need a sort of greater service integration, a more holistic approach. And in that conversation, we need an awful lot of more support for mental health. And there is that interplay between psychosocial, socioeconomic, healthcare interplay, which is really important. Someone's mentioned also about polypharmacy. Well, when I first started, you had a myocardial infarction, people were in bed for about 7 or 8 days and you went home. Now you come in and you go from 0 to 5 drugs in the space of about 24 hours. So we have a real impact. And you put all those clustering of diseases, we've got great healthcare for in particular conditions, but you get an awful lot of polypharmacy. I'll come back to a little bit about the research and the conclusion. So next slide. So most of the guidelines, as I've sort of pointed out, is that I've often specific. This is Scottish data. It applies to anywhere in the country. And my particular interest is cardiovascular disease. So if we just click on, you'll find that for those people who have only heart failure, only 3% of patients with heart failure just have heart failure. Next slide. And we're very good at guideline medicine. I sit on NICE guidelines for cardiovascular disease, and we're very good at sort of hypertension and lipids or whatever. But as you get to more long-term conditions or people who are living with frailty, we have to move a little bit away from guideline medicine. It's not going to give us the answer. And we need to be thinking more about care and support planning. Next slide. I think the final point I'd say in this introductory little bit is that multi-morbidity is not frailty. On the left of the slide, you've got Swedish data actually from the King Solon healthy aging study. And what you can see, if they've clustered together certain diseases, and the levels of frailty does vary between different types of multi-morbidity. And on the right-hand side, you've got the prevalence. And what you can see is multi-morbidity is very prevalent from the ages of 60, with frailty increasing as you get older. So multi-morbidity is associated with frailty, but it's not the same. Next slide. So I think people will know about the report from Claire Fuller, and was into the development of integrated neighbourhood teams. And this is where in South East London, this the idea of actually having a multi-morbidity project sort of developed from, really sort of focusing on that sort of those core issues in terms of having an integrated patient-centric, holistic, and just to pick up on Tanya's point as well about the importance of prevention, and also utilizing the diverse skills. One of the biggest issues is also reaching those who are difficult to reach, and there's an awful lot of social inequality within that. Next slide. So this is the multi-morbidity model that we are testing. And as I said, it's a very live process that's ongoing at the moment. And it falls into 3 sort of categories, really about trying to get improved patient experience. Now, we're focusing very much on CKD, but we've chosen CKD was chosen because it's a little bit more easier to identify, and we can use that as a model to see if we can then expand it to other areas. The bit I'm talking about is probably those who are just on the multimorbid, but we do actually have frailty aspects, and we have geriatricians associated with advanced kidney clinics, both at King's and at Guy's, which is something new. We're looking at ways of improved working because we can't carry on doing the same things as we are. We've got to come up with new ways of doing things. If you've got your CKD, diabetes and heart failure, you might get to a heart failure clinic, a CKD clinic, you might come and see me for your hypertension, you're so in a geriatrician as well. It's just mad. So all that leads to trying to increase the efficiencies across the whole of the process. Next slide. So the project's running across all 6 boroughs in South East London. As I said, I'm involved on the Lambeth side. A lot of time and effort went into developing the design and how we would run over a course of workshops involving all the boroughs and representation. The representation was very broad to get engagement. And we also had a secondary care group, really just as a touch point to oversee that liaison, because part of this is about trying to develop new ways of working between primary and secondary care. Next slide. So this is what we're doing within in Lambeth. We've version 2.6 of our SOP, which just goes to show you it's a very iterative process in terms of continuing to develop and remodel how we do things. One of the main aspects is trying to identify patients with CKD. And one of the fundamental first stumbling blocks was getting over the coding and the coding issues within primary care, which was a challenge. And then from having identified those with CKD, we look to see if there are people who are falling into ones who need a little bit more specialist care. We've got MDMs going. Next slide. One of the key components of this, though, is actually having the care coordinators in primary care. So they get information that we do centrally within the primary care network. We send the practices a list of people who we think might have CKD, and they can then reach out to them. We've set up a whole new system, but it's using the people who are already there. It's just a different way of operating. So we now actually have a single point of access for myself, a renal physician, a cardiologist and diabetologist in terms of advice and guidance. And the idea is trying to prevent need for hospitalization. It also helps in terms of cross-fertilization of education and aspects. And on top of that, we now have, and as I said, as you can see, these are the dates, a very live process in terms of a multidisciplinary meeting between ourselves in primary care and primary care colleagues and ourselves in secondary care. Next slide. So this is very fresh. This is some of our latest information. We're a long way from actually we're probably a few months off from actually finishing the project and then going towards analysis. So this is very live, very raw data for you, and some of my thoughts. So first of all, I think one of the things was about case finding. It was really important to try and getting all that coding right. And in fact, from the start of the project in April to December in Lambeth, we have identified 596 new CKD 3 or above cases of which actually, if you look down the slide, has had a real prevalent impact on the prevalence. We knew the prevalence of CKD was probably lower than it was the national average in South East London, and it does vary from practice to practice. So take on the Clapham PCN, we've gone from 2 to 2.7% for our CKD prevalence. That's a 25% increase from just getting the coding right. And once you've got the identification, then you can maybe start thinking about intervention, maintaining and making a difference. So just going back up the slide, the coding and coding correction, because there are some people who are coded incorrectly, that they've got CKD, but they don't. If there was a one-off acute kidney injury episode, they don't actually have CKD. So trying to get the coding right is a real primary step. I've talked about upskilling. We've upskilling the care coordinators. We're looking at that in terms of supporting from primary care, secondary care, running training programs for that. And also in terms of, to some extent, there's a little bit of hand-holding. I'd also probably say that I've learned an awful lot myself from my renal and diabetic colleagues as well. So as well as cross-fertilization between ourselves and primary care, I think there's cross-fertilization within primary care and within secondary care. There's certainly been a much greater focus now on CKD, and there's an awful lot more team collaboration, a real multidisciplinary teamwork. And I think the integration is beginning to improve an awful lot in terms of developing those relationships between primary and secondary care. Moving on. Next slide. So this is some of the, this is only about a month old. We just did a staff feedback. And the good thing is, as well as getting very positives, we've also got we got useful feedback in terms of things perhaps we can improve on. So this, as I said, it's a very iterative process. But the general feeling is that we're moving in the right direction. Next slide. I'm going to give you some take-home messages. No. So this has been a real whistle-stop tour. Multi-morbidity, it is challenging. We've been talking about frailty, but multi-morbidity is challenging. It's challenging to health and social care professionals. It's challenging to the patients. It's challenging to the carers in terms of trying to balance up all the different systems. You do, without a shadow of a doubt, need a holistic professional approach. And then without that, we're not going to be able to address the issues. I'm going to bang my drum again. I do think we need a generalist approach a lot of the time. And we do have a little bit of over specialization. But we do need a different system-wide integrated approach. And I think the final comment I'd make is that if you look at the trials for intervention, often some of the trials for intervention don't show benefit. But if you look at the observational trials, they do show benefit. And I think that's one of the important key aspects, is not to give up too soon when you're changing something, because it's all about relationships, and you need to embed those relationships, and those relationships take time to develop. So very whistle-stop tour, so thank you very much.
Thank you, Nigel. Unfortunately, we don't have much time for questions, but I do just want to tie together what we've heard. Jagdeep, thank you for your bit around really the importance of stratification, segmentation, the importance of population health data, preventing frailty and preventing crisis in frail patients. We then moved on to Tanya's importance of pulling all the actors and the players together. And I think we have been lucky in South East London with the historical interest in this area. So aging well and the strategy around that, really key. And then the implementation, Lucy, of what you've managed to do in Frimley in a focused model is really helpful. What is absolutely key is showing the cost benefit of that, because I think that's going to become increasingly important over the next few weeks. Multi-morbidity, those were beautiful slides, Nigel, and a really interesting use of the CKD model. But I suppose what we have demonstrated here is just around frailty and flow, and some of our most frequent flyers of our unscheduled care services and our scheduled care elective services. We are hitting all of the 3 shifts, so analog to digital, hospital to home, and treatment to prevention. We also are improving the primary and secondary care interface, which is another focus at the moment nationally, and then just improving and strengthening the integrated neighbourhood teams, who I think I can, with a degree of confidence, say I think will survive whatever else is tumultuous at the moment in our context. So a very, very, from my side, my gratitude, and all of you have joined. We had just under 100 people at one point. To all the speakers, Jagdeep, Tanya, Lucy and Nigel, thank you very much. And I'll let John finally close. Thank you.
Oh, Dagny, I mean, it's the Cheltenham Festival at the moment. I don't think any of the runners there have galloped quite as powerfully as our speakers today have gone through their presentations. That was simply sensational. I mean, I came on as a non-clinician, didn't really know a huge amount about the whole landscape and local level solutions. You've completely opened my eyes. Thank you to everybody concerned. Really appreciate it. Can I also have a big shout out to the people behind the scenes who've made all of the transition of slides possible and so on. That would be Jade and so on as well. Really appreciate it. Let's do another one of these again on a different topic. That was fabulous. Thank you very much, everybody.
Thank you, John, and enjoy your rest of your afternoon, everyone. Bye-bye.